Our next speaker doesn't really need much introduction. So Dr. Roach is the Chief of Neurosciences here at Dell Children's. He's also the reason that I came here. So when I was a med student, I was in Fort Worth, and my mentor in med school, Scott Perry, was like, you need to go to Columbus and meet this guy, Steve Roach. And so I flew up there for my interview. I was like, this is my number one place, matched there for residency. And then while I was in Columbus, Dave Clark came to visit. And so one of my mentors in Columbus, Anoop Patel, was like, you got to meet this guy, Dave Clark. And so I met Dave Clark, and I was like, man, these are two incredible people in epilepsy and pediatric neurology. And then they end up in the same place, when I'm looking for a job a couple years later. And so I basically had to come here, right? So that's how I got here. So without further ado, Dr. Roach.
I thought about making a joke about something like it's the only job Dan could get, but I won't do that. He would have been a hot product anywhere. So these are clinical pearls, we call them, kind of designed to be bite-sized bits of learning for, during your bite-sized bits of lunch. Nothing to disclose. I'm going to talk about this little girl who came in to see me through our same-day, next-day appointment process back last fall. And for those of you who haven't used it, we've got a simple number. You call it a cell phone physician or nurse practitioner only. We can get the patient in the same day or the next morning, depending on when we get the call. If we need an EEG, we can get that the next morning as well. It's been very successful. And anyway, this girl is 9 years old, and she was sent to us for possible, because she had a seizure, what was thought to be a seizure after waking. They described it as bilateral twitching movements of the arm, the face, the hands, followed by lethargy. So thinking back to Dave Clark's presentation this morning, that sounded pretty good for a seizure, right? Curiously, during this episode, the family said she could still make eye contact, but she couldn't speak. And then when you talked to her later, it was quite clear that she said, well, I could still understand everybody. Well, is that true? She was able to provide enough details of this that she probably could. So here's someone who was having twitching movements, couldn't speak, but was still making eye contact, and then later could tell you enough about what was going on that she was at least somewhat with it. So again, another example of someone who's turned out to have seizures, but maybe not fitting the classic mold. Curiously enough, during the past year, she had had several episodes where she woke up kind of shivering or quivering, that they thought maybe she might have had a cold or something like that. They kind of blew it off. And the other thing that fits into this that comes up and is the reason for talking about it today is for the last year, this little girl who had been like the head of her class in elementary school was struggling to pass. So a terrible deterioration in school performance. Now, she was a great student until age 8, straight A's. They described the school business as poor focus, poor conceptualization, having difficulty with things that she used to have no difficulty with whatsoever. This is a little nervous going through this because I have our chief of neuropsychology sitting over here nodding at me right now. So, and it was clear that this was not just a school thing. If you say, well, how does she do when she's at home, chores and interaction? She was globally struggling. And so this kind of takes away, you'll see these kids who have a kind of, something's going on with school, and as long as they're able to play video games and play with their friends, they're fine, but in school, no, this was not that. This was global deterioration. The other thing that was important, and we'll come back to this a bit, is her performance varied wildly from day to day. This is an important thing. We'll come back to that. But so one day she would go, her apparent effort was fine, her behavior was never a problem. But one day she would go in and really struggle and learn practically nothing. The next day she would go in and with the same apparent effort, the same teacher, the same subject matter, she was kind of like her old self. But then when you averaged all this together, you know, occasional good days, a lot of bad days, she was struggling. She was initially diagnosed with attention deficit disorder, and somebody put her on stimulant medicine. It didn't help. So they moved on and said, well, okay, it's obviously not attention deficit disorder. So they put her through some testing and so on and said, aha, we've got the answer. She's got a learning disability. And so they made all kinds of accommodations, additional time, additional tutoring, things like that. Nothing worked. Now, pause, let's do some classical medicine. You know, rather than just jumping on something, you know, you like to force yourself to consider all the options, you know, so a differential diagnosis. Well, you can do two different differential diagnoses here. You can do one that's kind of seizure-related. And then there's the other one. You could say, well, okay, what about school failure, you know, and then most of us don't believe in coincidence, so, okay, what's the differential diagnosis that might cause both seizures and school failure? Well, that list, I've expanded just a wee bit here, and that list is pretty scary, the things that will cause school failure and seizures. So epilepsy itself, you know, a brain tumor could cause poor cognition, deteriorating performance, certainly seizures. A lot of genetic disorders, Batten disease, you know, some of the, well, many of them actually, you know, will cause, anything that causes seizures with those, sure, can cause epilepsy. Toxic metabolic things, lead toxicity, things like that will cause seizures. It'll cause increased intracranial pressure. It'll cause cognitive impairment. And you can get then into the realm of emotional trauma, things like that. You know, is there someone at school abusing this child? Is there someone at home, you know, their crazy Uncle Fred is crazier than we even knew, you know, doing something to this girl that's just kind of rocking her world and doing everything. But again, many of these are really tough diagnoses, you know, that you hope to never have to deal with. But let's stop and analyze what we have here. Because a lot of this, you know, we could sort of sort through even before we got the EEG that I'll show you in a moment. So again, going back to that differential, the course, a year course, and we're working on the assumption that these morning, quote, shivering, quivering episodes are probably seizures also. But a year course is going to be far too long for a brain tumor, at least most of them. You can have them develop over a year, but she ought to have more than she had by now. Same thing is true for toxins. I mean, it's hard for me to imagine her having enough lead toxicity or other toxicity to be causing problems a year ago that's, you know, hasn't killed her or is looking much worse. So the course, the trajectory of the history can help you all but eliminate some of that. ADHD, yeah, you know, that doesn't begin at age 8. I'm sorry. It's sometimes diagnosed at age 8, you know, I mean, the diagnosis is delayed, but that's very different from it starting, you know. I don't know that I've ever seen a single kid with a plausible diagnosis of ADHD who was an A student until age 8 and then went off the rails because he couldn't pay attention. Same deal with learning disability. I mean, no, it's just, it doesn't work that way. And here's the other big clue. The near normal performance on some days, that virtually eliminates a lot of these genetic disorders. Those aren't going to change. You know, that you're on a downward spiral, and you might have, you know, relatively good days and relatively bad days, but you're not going to have a normal day mixed in with that. You're just not. On the other hand, you see that pattern all the time with epilepsy. And in fact, that's a really great clue. So much so that when I have a kid that comes in and they're not doing well in school, I give them a chance to say this, but they won't. And so I ask them, is the poor school performance, is it the same every day? And when you start getting, no, some days it's fine, that's a really useful clue. And even if you have no indication of seizures, that's a reason for doing an EEG, I think, in that setting. So we concluded, even before doing the EEG, that this girl's overarching problem is probably going to be epilepsy. Here's our EEG results, at least one page of it. And by now, after this morning, you should be expert on all things EEG. And she's got a classic pattern. So in the second cluster there toward the top, you see all those kind of Sharpie waves there in the middle that aren't seen in the others. These are coming, if you kind of track back the code on the left, at our scheme of things, odd numbers are left, even numbers are right. These are coming out of the right central area. So these are central spikes. And you'll see this, the old nomenclature on this is Rolandic epilepsy. It's a fairly benign seizure pattern. It picks up, along about 5 or 6, 7 or 8, usually resolves. But in the meantime, it'll wreak havoc. They can have seizures a lot of time early in the morning. The other thing is they're known to occur a lot at night. Even if you don't see overt seizures, you do an EEG during sleep and it's crazy, a lot worse. And so this girl had benign epilepsy, central temporal epilepsy. You still have to treat it. Some people would say you don't have to treat it if you're only having them at night and so on. I'm a little nervous about that, but certainly in this girl who's having poor school performance, yeah, you got to treat it. So her diagnosis, benign epilepsy with central temporal spikes, epileptic encephalopathy with acquired school failure. And indeed, when we put her on a medicine, had to adjust it a little bit, but the parents called up 10 or 12 days after we started on medicine, and just, it's a miracle. Because, she hadn't had more seizures, but what they were referring to is this girl who for a year had been making D's and F's instead of her usual A's, no A's and B's, and just in just over a week, she was back to normal. It's that dramatic. So take-home pearls. Nocturnal or subtle daytime seizures. This kiddo could have had a subtle absent seizure, stares that people were just blowing off as daydreaming. Could have done the same thing. Can thoroughly disrupt cognition. It's transient. You fix the seizures. You're not, as far as we know, you're not damaging the brain long term. It is important to treat it though. So proper treatment will not only stop the seizures, it'll fix the cognition, just like in this girl. The other thing, I think everybody knows this on some level, except maybe the place where this girl came from. Neither ADD nor learning disability are going to start de novo in a previously well child at age 8. I'm sorry, just doesn't happen. And then remember the exceptional clue, pearl, is ask them if their performance is the same day after day after day. If it is, it might still be something like this. But when you start getting this pattern where, some days are really great and others are not, that clue alone excludes a lot of the things on the differential. So that's a take-home right there. So anyway, short and sweet. Thank you. Questions? Okay.